We'll move on to the last talk before lunch. I'll request Dr. Ashita. She's a consultant cardiothoracic radiologist at Jayadeva Institute, Bangalore, and she's going to talk on the role of MR in atrial assessment.
Thank you, and we're down to the last session of the collaboration between IAE and IACI. So my talk is on atrial assessment. So the objectives of my talk is to give you a background of the importance of assessing atria in, by cardiac MRI and in any pathology. And I'll give you a brief importance of CMR and how does CMR score over echocardiography, which Dr. Satish Govind has already actually stressed upon, and sequences for atrial assessment on CMR, a bit about the atrial volume, strain, and LG, which have prognostic implication, a few case examples beyond structure and function, and I'll end my talk with that. So what's the importance of assessing atria in cardiac pathologies? So the changes in atrial size and function are a surrogate marker of ventricular dysfunction. Atrial cardiomyopathy, which is a relatively new entity, may also occur as a primary myocardial disorder and needn't be only a part of because of ventricular pathology. And atrial cardiomyopathy has a potential risk factor for atrial fibrillation, heart failure, and thromboembolic stroke, but it needs for better atrial metrics in clinical practice. Atrial mitral regurgitation is also has also gained recent importance. So basically, this is a mitral regurgitation which is primarily due to atrial dilatation, which leads to mitral annular dilatation, and this has regained recent importance. So what are the key barriers in atrial assessment? It's the lack of standardized criteria or hierarchy for the diagnosis of atrial cardiomyopathies, the generalized definition of atrial cardiomyopathies, the lack of consensus for the most accurate phenotyping methods, need for post-processing software for the assessment of these atrial metrics, and need for post-processing vendor-specific normal strain values for the population, and the limited data that's available. Allowing for all this, let's move into what are the modalities that are used for assessment of atria. As we've seen and heard before me, 2D echo and 3D echo, and how 3D echo scores over 2D echo, CMR and CT. So why cardiac MRI is useful and how does it score over echocardiography? As we all know and we've seen in this whole conference, cardiac MRI has excellent spatial and temporal resolution, reproducibility and accuracy, and tissue characterization, all what make it the gold standard technique for non-invasive assessment of not just ventricular assessment, but also for atrial volume and function assessment. CMR overcomes the main problem of echocardiography, as detailed by Dr. Satish Govind, that is limited acoustic windows. It therefore reliably provides accurate atrial metrics in all patients, not even those which cannot be seen properly on echocardiography. So the disadvantages are it's expensive, there's limited availability of cardiac MRI as compared to echocardiography, and there are some potential risks which are although very, very low. So what are the planes there in which you can assess for atria? So I've included in this slide, I've included, I'm seeing my pointer. Okay, so I've included both atrial and left atrial assessment as well as right atrial assessment. This is the 3-chamber, 2-chamber, and the 4-chamber view, which I use for the assessment of the left atrium, and the RV2 chamber view, which is along with the 4-chamber view, which are used for the assessment of right atrium. The other thing that we can do is actually take short axis stacks, just like the ventricular stack, and then calculate the atrial volume and the atrial size on the short axis stack of the atria. The usual sequence, fallback sequence for us is an axial cine sequence, which covers the entire heart as well as the atria, and you can assess the atria on that. So atrial volume assessment can be done and on the 4-chamber, 2-chamber, and 3-chamber view. These are the ways that the diameter is measured. The right atrial, this is for the left atrium. The right atrium can be assessed like this on the RV 2-chamber view and the 4-chamber view. What's important to know is LA dilatation occurs in an asymmetrical manner. Medial, lateral, and supero-inferior directions is in which it occurs, and therefore indexed LA volumes, that's LAVI, is the preferred method for atrial sizing. Normal values are given in this reference. Please refer to it before giving your results. So let's understand a little bit about atrial physiology before going into the importance of detecting these volumes. On the top, you can see the animation of LA volumes. The figure shows the ECG and what happens. So what happens is it's divided into three. That's the reservoir phase, the conduit phase, and the booster pump phase. So when the atria gets filled up with blood from the systemic from the pulmonary veins in case of left atrium, this is called the reservoir phase, where it passively fills up with blood, and then the reservoir strain is the maximum strain. And then what happens is the mitral valve opens and the blood is emptied into the ventricle passively. When the left ventricular pressure equals that of the atrial pressure, then the booster pump phase comes into action, where the atria contracts actively and pumps the last amount of blood in the atria into the ventricle before the mitral valve closes. So what you can understand by this physiology is that there is a lot of interdependence between the ventricular diastolic pressure or the ventricular filling pressure and the emptying of the atria into the ventricles. So therefore, the importance of atrial size and the size is that it is the net effect of LV filling pressures over time is determined by atrial sizing. It's an index of both the chronicity and severity of LV diastolic dysfunction. It's an early marker of ventricular disease. It's a prognostic marker of adverse cardiovascular events and all-cause mortality, and aids in the diagnosis of atrial cardiomyopathy. Both transthoracic echo and cardiac MRI have been used to assess reverse atrial remodeling, and although there's no approved definition, it is considered that a 15% reduction in initial left atrial volume mirrors the degree of reverse remodeling. So what are the limitations? Only one aspect of LA performance, that is volume, is assessed by the sizing is assessed by left atrial volume, and it does not capture atrial function. And LA dysfunction may precede changes in LA size. So how do we assess LA function? Okay, so this is by what Dr. Richa has just spoken in detail about the ventricular strain. Atrial strain is the parameter by which we assess the atrial function. And Dr. Satish Govind has shown how to assess the atrial strain on echocardiography. The feature tracking strain is also similarly assessed on for the atria, just as the ventricles and just like echocardiography. Again, you will have in the strain, you can calculate the reservoir strain, the conduit strain, or the booster pump strain, and this is affected in different cardiovascular pathologies. So this is the way that the software that I use shows up the atrial strain here. In this image, we see the calculation of the left atrial strain here, and the left atrial strain is 53%, which is within normal limits. The important thing to know, and this is one study that showed a good correlation between transthoracic echo and cardiac MRI for atrial strain parameters. What we also have to know that a left atrial strain is a marker of atrial functional status, which is a subclinical phase of a disease, and it can be, therefore, strain can pick up even before clinical onset of a disease. Strain impairment is also before the onset of left atrial enlargement, and LA strain indices are predictive of atrial fibrillation onset in patients with risk factors for stroke, but without any history of atrial fibrillation. Guidelines recommend evaluating LA size as a marker of LV filling pressures, and LA strain is a promising marker and a better predictor of outcomes than LA size. So where is atrial size, atrial strain right now in clinical CMR practice? It's limited due to measurement variability, which is inter-vendor variability. There are three main factors for this. That is the imaging modality, the software, as well as the operator, and there's a need for technical validation. The guidelines suggest that LA lateral wall strain can be reliably measured by CMR, and there's significant alteration of the LA reservoir strain, which predicts poor outcome. No new sequences are required for assessment of LA strain. So start performing LA strain routinely, even if you're not going to use it clinically if you have the software. Establish normal values for your vendor. So RA strain, both atria have important and different functions during the cardiac cycle. Right atrium is now being considered as more than a passive chamber and can be subdivided just like LA strain into the three phases: reservoir, conduit, and booster. It has a role in pulmonary hypertension, ischemic and non-ischemic cardiomyopathies, as well as HFpEF, just like LA strain. So this is the way that the software I use throws out the right atrial strain. It's given peak right atrial strain of 57%, which is within normal limits in this case. So the practical difficulties, let's finish. We finished with volumes, we finished with strain. Now let's dive into LGE. LGE is basically, you do high resolution atrial sequences, contour the atrial wall. You can see how difficult it's going to be to contour the atrial walls, and then calculate the amount of fibrosis. The difficulty in this is that it's not easy, and you need a software, post-processing software. This is the Utah classification, with the least being less than 10% and the most being more than 30%. Once we quantify the scar, they go ablate it, and post-ablation, you can again, if there is recurrence, you can look at the gaps and then let them know where to ablate again. But the recent study, the DCAF study, showed that the DCAF2 study failed to demonstrate that CMR-guided fibrosis ablation was better or superior than preventing arrhythmia recurrence than just pulmonary vein ablation without using CMR. So atrial fibrosis in patients with AF is associated with thromboembolic events, and atrial structure and remodeling in patients without AF has a prognostic implication in different diseases. Now, volumetric assessment of epicardial adipose tissue is of importance, and Dr. Vineet showed this in the pericoronary region yesterday, and here I'm showing how you can assess the left atrial epicardial adipose tissue, which also has importance and has an association with atrial fibrillation. So let's just dive into a few interesting cases here.
Please, Ashita, can you make it fast?
Yeah. So this is, again, a pseudotumor, which was already seen on echo. It's crista terminalis. And then here you can see the Q-tip sign, like Dr. Satish Govind said, which is, again, Carmadine ridge. And here is looking at the left atrial appendage thrombus on cardiac MRI. And this is a mass which is involved the right atrium. It's infiltrated. This is actually courtesy Dr. Rajesh Kannan. And here you can see a lung lesion, and this ended up being cardiac aspergillosis. This is another common left atrial mass that you can see. It's classical for an atrial myxoma. And atria, obviously, we know that volume overload conditions include congenital heart disease. And here you can see a left to right shunt at the atrial level. It's an ASD. And you can quantify the ASD using the QPQS by cardiac MRI. So this is another interesting case which shows atrial involvement, mass-like atrial involvement, biatrial thickening. And this is a case of Erdheim-Chester's disease. Another condition, common condition that's been shown before is with atrial involvement is cardiac amyloidosis. So to conclude, cardiac MRI is useful for assessment of LA shape, dimensions, and the antrum of pulmonary veins, including anatomical pulmonary venous variants. Cardiac MRI strain assesses basic atrial function and has early diagnostic and prognostic information in multiple cardiac diseases, but affected by inter-vendor variability. The detection and quantification of atrial fibrosis non-invasively provides important pre and post ablation information, and cardiac MRI has also been demonstrated to be useful in the characterization of intra-atrial masses and involvement of other systemic diseases. So therefore, to conclude the session, the IAE and the IACI session, the importance of cardiac MRI in atrial strain is basically because echo has a limitation with imaging window, which cardiac MRI doesn't have. It's a gold standard for atrial size and volume calculation. It has an excellent visualization of atrial wall. It has high spatial resolution to define endocardial borders and therefore useful in strain imaging. It's the gold standard for tissue characterization. Whole heart epicardial adipose tissue volume can be calculated by cardiac MRI, and it gives an accurate view of LA shape without geometric assumptions. Thank you.
Thank you, Dr. Ashita. I request Dr. Nisab to give a quick summary of the multimodality approach for cardiac imaging.
Excellent session. I hope everyone has learned a lot. I certainly did. And multimodality imaging is very important to patient care. We need all of these tools. Echo has excellent temporal resolution, especially for valvular heart disease. CMR has good ability to do tissue characterization and also imaging planes, when echo is difficult. So I hope that we continue to improve on all these multimodality imaging tools so that we can deliver the best care to our patient. And off to lunch for everybody. Been very patient.
Thank you. I request Dr. Priya Jagia to participate. Dr. Ashita.
Thank you, Dr. Rajesh and Dr. Vanessa. Thank you very much.